It's letting me record too. So. Am I a host? I can't have to admit. Katrina, am I a host? Because I'm getting to admit people here.
Yeah, you're a co-host, but don't worry, I'll cover all that.
All right, I saw a familiar name. I think one of our folks just showed up.
Awesome. All right, so we're gonna go ahead and get started. Let me go ahead and fully share my screen here.
I may have muted you. That was me. Sorry about that.
No worries. Thanks for letting me know. All right, everyone, we're gonna go ahead and get started here. Thank you all for joining us for the New Face of Weight Loss webinar. My name is Katrina. I'm VP of Operations here at BodySite, and with me today I have Dr. Clearfield, a wonderful doctor and client of BodySite's. So just a little summary of the agenda today. We have some housekeeping items to cover. I will be covering BodySite's new semaglutide program. I'll pass it over to Dr. Clearfield for his great presentation that he's prepared for us. And then we'll go into a brief Q&A session. Regarding questions, as you have questions throughout the presentation today, whether they're related to BodySite's semaglutide plan, any questions about semaglutide that Dr. Clearfield might be able to speak into, or questions about anything he covers in his presentation, go ahead and send those in the chat box, and then we will cover those at the end during the Q&A session. All right, so as many of you probably know, we have our new semaglutide weight loss plan. This plan is a 10-week support program that is really used to help you provide additional value and support to your patients who are using semaglutide. This program includes education about semaglutide, the benefits. It has an how-to video, has healthy recipe ideas, tasks to increase compliance, and general health and wellness tips. So basically the overall plan details of this new program. Number one, like I mentioned, it's 10 weeks in length. This plan, just like all BodySite plans, are fully customizable. So if you wanted to change out the video on day one, if you wanted to add your own personal touch to it, you can customize anything about this program. It includes a weekly task for administering the injection, as well as a weekly task for tracking weight. As I mentioned, there are daily general health and wellness tips for overall well-being, as well as daily breakfast, lunch, and dinner recipe ideas. These recipes are lower in fat, with lean proteins, including plant-based protein options that incorporate whole grains, fruits, and vegetables. I would say the overall diet approach is that of a paleo or anti-inflammatory like approach. Optionally, as some people have asked about this, the plan can be paired with an exercise or movement program, such as BodySite's at-home fitness plan, the new HIIT plan, or even just a basic walking plan. We understand that everyone is kind of at different levels, so we've intentionally not put a specific exercise program into this program. Instead, you would basically put your patient on the semaglutide program as well as the exercise or movement program. And it's very easy to toggle between plans in both the web platform as well as the mobile app. Awesome. As I mentioned earlier, we have with us today Dr. William Clearfield. He is a graduate of La Salle College and the College of Osteopathic Medicine and Surgery. completed a rotating internship and served as an OBGYN resident at the Metropolitan Hospital, certified by the American Board of Family Medicine after completing a family practice residence in 1982 at United Health and Hospital Services in Kingston, PA. Dr. Clearfield, since 1982, has been a lead figure in family and integrative medicine. With graduate expertise in areas ranging from cardiac rehabilitation to age movement and non-surgical aesthetic medicine, Dr. Clearfield, a leading authority on cutting-edge medicine, is a prolific and popular speaker, regularly addressing the Age Management Medical Group, the American Academy of Anti-Aging, OMED, the American Osteopathic Association's Scientific Convention, among others. So thank you, Dr. Clearfield, for being here with us today. We're so grateful for your expertise. So I'm going to pass it off to you to share with the group.
Okay, thank you. So I'm assuming most everybody here is a body site, the customer, resident. Correct me if I'm wrong.
Looking at it, it's kind of like a mix. I think we have some body site subscribers, some non, but most should at least be somewhat familiar.
I'm going to be alluding a lot to body site. I was maybe one of your first customers. I've been with you however long you've been. I think at least 10 years.
Yeah.
Way back when I think you had three plans in there, MCD or something. And if you're new to body site, I mean, it's really a great tool. We use it every single day, and it saves me a lot of time. It saved me from having to. I mean, we do have a nutritionist that we hire out, but from hiring an in-service, an in-house nutritionist, we made our own programs. And if you're new to it, get familiar with it, and it really is something that I always wanted to do on my own. So just a little bit of background: in 1984, way back in the dark ages, on an Apple IIc computer, if you remember those, you probably don't remember that, Katrina. It had a 5¼ inch floppy disk and 128 K of RAM. We actually wrote a diet program for individuals, and we would put their name in, their height and their weight, and it would give us recipes and menus for a week. And it was kind of crude, but it was a big hit, and I was actually on the news back where I was in Pennsylvania, and it was something of a sensation. I was never able to put it together the way you guys have, and I'm really happy. We've been really happy with the whole thing. So today's topic. This talk actually came out of something that I did at AMMG in April, the new face of weight loss. Since we want to concentrate on semaglutide, and I'm going to change it a little bit, and I talked to you about this yesterday. I'm going to call it the incretins, because there's more than one now. Semaglutide was the first one that was released, but there's two, and I'm going to show you actually a third one with up to the minute information that was published on Monday about one of the incretins. So that will be our emphasis, but we're going to look at an overall view of dieting, how we handle it, at least in our practice. We'll go over some diet overviews. I'm not going to go into any details. We'll talk about semaglutide and tipirazide, which are the FDA approved substances that are available, although tipirazide is not FDA approved for weight loss at the moment, but it's coming. And we will talk about some other interventions that we do. We'll talk about complications, how to handle the complications. And we're going to talk a little bit about maintenance also. There's a big thing going. Well, you're going to gain 2/3. There was a study out just recently. 2/3 of the weight gain is the weight is regained once the patients stop the medication. So we'll talk about how to get around that also, with also something fairly new. So this was a CME lecture, or part of it was. It's a little bit different than what we did at AMMG. So we don't really have anything to disclose. We're going to talk about a brief history of diets. I shortened this now. down. I like doing this first because what it does is it shows that everything old is new again. And I'm going to show you two diet plans that were developed in the 1800s, and you won't believe I didn't believe it at first, and I thought this was a great thing to show everybody. How did we get here? Up to 70% of the U.S. population is now considered obese in some counties. We'll talk about the 4 pillars of weight loss, and again, we're going to talk about interventions. Mostly, that's the topic for today. But we'll talk a little bit about the evaluation, practitioner interventions, and we'll give you some tips and tricks. So where to begin? So there's a lot of confusion with diets. This was Time Magazine over here on the left in 1984. Cholesterol was bad. 2014, cholesterol was good. And as you know, anybody who's worked with overweight, with weight issues and obesity, the misinformation is as long as your arm. What's so great about kale? Will red meat kill me? 1 week coffee's good for you, another week coffee's bad for you. High fat diets are out, high fat diets are in. High sugar diets are out. High sugar diets, well, maybe it's not so bad, it'll only rot your teeth out. So we'll try to dispel a couple of those myths. So I'm going to start here. In 1825, believe it or not, this fellow was Jean, he was French, Jean-Anthille Brillant, and he was a chef. He was also a politician, but he was a chef. And he wrote this book called The Physiology of Taste. And it was one of the early sort of pamphlets. And what he said was that carnivorous animals never grow fat, and herbivorous apples do not grow fat easily until they age with reduced inactivity. They fatten quickly as soon as they are fed on potatoes, grains, or any kind of flour. Does that sound familiar? The chief causes of obesity is flourily and starchy substances, which man makes the prime ingredients of his daily nourishment. And all animals that live on farinaceous food grow fat willy-nilly, and man is no exception to the universal law. So he's advocating a high-fat, low-carbohydrate diet in 1825. So that was, he was a Frenchman. This young man was a funeral director in the 1860s in London. This was his picture of him he wrote this, it was called The Letter on Corpulence in 1862. And this is actually, believe it or not, the same man in 1869. And he stated, of all the parasites that affect humanity, I do not know of, nor can I imagine any more distressing than that of obesity. He could not stoop to tie his shoes, nor could he attend humanity's offices of humanity without considerable pain. He had to go down backwards from stairs to save the jar of weight increased upon his ankles and knee joints, and he was obligated to puff and blow with every slight exertion, particularly going up the steps. He had no bill of fare, or he had no roadmap to know what was really intended, and he brought himself into a low impoverished state by following the guidelines of the day. He had many obnoxious boils appear and 2 rather formidable carbuncles, which he had to be operated on. He was then fed into increased obesity. So his cure for corpulence, he cut down from 4 meals to 3. He recommended vegetables of all kind from above the ground except peas. Fruit was less likely to increase weight if it was cooked without sugar. Fat was to be skimmed off of gravies and jellies, and expressly prohibited bread, milk, butter, beer, sugar, and potatoes, and all root crops, including carrots, turnips, parsnips, swede, and beetroot. This was his daily breakdown. This was for breakfast, lunch, dinner, tea, and supper. And he had 1,700 calories on average, 115 from protein, 22%, 42 calories from fat, 119 from carbohydrates. But this was the big controversy of the day. Only 23% of his calories were allowed to come from alcohol. And for this, he was denounced actually in the British Parliament for being, a sort of a heretic. So again, this was 1862. Fast forward 100 years, 1972. Atkins, in the midst of the beginnings of the low-fat craze, stated that it was low fat diets and high fat diets and low carbohydrates were the keys to a healthy body. So again, the point being is that there's nothing new under the sun. These are obesity trends. This was from the U.S. Department of Agriculture in the 1990, which was 30 years ago. The light blue is less than 10%. The darker blues were 10 to 14% of the population in 1990. Those of you who don't know, I live in Nevada, which is here, which was white, which they didn't bother. So in 2000. Most of the western part of the country was at 15 to 19%, and the middle of the country 20 to 24%. By 2010, it was even worse, greater than 30%, especially here in the sort of the Bible Belt. And here, this was a different colored graph, but in the darker reds here, we're up to 40 and 50%. So you can see the trends from 10 to 15% of the population to more than half of the population. So what happened? So every cardiologist that you talk to will say the patient's cholesterol should be 0. I mean, I've heard that. They wanted the LDL less than 70, and fat, fat is your enemy. When we point out to them that the brain is 60% cholesterol, they don't want to hear it. So it's a kind of a constant tug of war. So the low-fat, high-carbohydrate diets took hold in the early 80s to late 80s, and within 5 years of the medical community's acceptance of low-fat diets, of course, we've developed a health crisis. So the U.S. Department of Agriculture, this was those of us of a certain age. You can tell by my hair; it's silver, by the way, that I've been doing this for a while. This was the USDA's food pyramid. And at the bottom was 6 to 11 servings of bread, rice, cereals, and pastas. And at the top, a little bit of fat, maybe meat and poultry here, 2 to 3 servings, milk, yogurt, cheeses over here, also 2 to 3, and vegetables somewhere in between. And remember, vegetables, even though they're most of them are good carbohydrates, are still, and fruits are still carbohydrates. Fruits, as you know, have sometimes contain a lot of sugar. And our rule of thumb for that, I didn't go because I didn't have time, didn't go into the glycemic index here, but fruits that are watery, if you bite into them and you get all wet and sloppy and you need to clean yourself up, like melons, oranges, those kinds of things, those are high in sugar. The moderate glycemic index fruits are the ones that have a little bit of water. So we're talking maybe apples and oranges, even pears, and the berries seem to be the best of the bunch. So what happened? We did it. Our doctors did it. We started this dumpster fire, and right here, this is where the low-fat craze began. And about 15% of the U.S. population was obese in 1985. And by the 2010, 2006, it was up to 40 to 50%. And I've seen in some areas over 70%. So just like the Hashimoto's autoimmune thyroid crisis that we fostered in the late 40s and early 50s, it's really on us. We did this because we thought we knew better. So what are we going to do about it? So in our group, what we do is we look at what we call the 4 pillars of sort of a healthy lifestyle and weight loss. So we're going to look at some nutrition. We're going to just do a little bit. Those of us that are a little bit more mature, especially, well, I'll talk for myself. I really had a difficult time with this concept of chronic inflammation as being the root cause of all disease. So we'll talk a little bit about that. I'll give you a short analogy. Hormone restoration is vital. Our practice is mainly focused on hormone optimization, and that's a whole year's course. I'll provide you with a little chart that'll tell you, which hormones, what each hormone does. There's actually some doses in there, and what to look for with deficiencies, but that's really not the focus here. And I sent to Katrina, and if anybody wants it, we do have a mind body program, and it's an 8-week program that we use with our diet program. It's pretty much a handout checklist. The patients fill it out at home and they bring it in, and we'll go over it. And if anybody wants that, you're more than welcome to have it. It's 8 weeks of sort of mental exercises, really. So nutrition. So the standard American diet creates inflammation. I think we all agree on that. There's no question about that. We take in too much fat. Results in chronic inflammation and insulin resistance. We also eat too much salt and sugar. And the aforementioned autoimmune crisis, when the U.S. government decreed that they were going to take iodine out of the food supply because it had been determined erroneously that it was a poison. And also at the same time, fluoride was put in the water supply in 1947 in 60 major U.S. cities. It took 5 years for the autoimmune insufficiencies to show up in a major way. So they, of course, they realized they had made a mistake. And even then, politicians they never make mistakes. So what they did was they stealthily decided what do Americans eat too much of, and it came down to salt and sugar. So they decided on salt. So that's where iodinized salt comes from, actually. So we iodinize salt so to try and put the iodine back in the food supply that had been taken out. And it was hailed as a great breakthrough, but that's a story for another day. So chronic inflammation, insulin resistance results in increased triglycerides, blood sugars, abnormal cholesterols, increased blood pressures, waist size, sleep apnea, and it leads to all sorts of chronic diseases that you see down there at the bottom of that pyramid. This is a chart just of sort of some popular diets that came about in the aftermath of the low fat, high carbohydrate craze. And the one that became the most popular was the Ornish diet. Dean Ornish was a physician in I think at UCLA. Now, I was living in Wilkes-Barre, PA, and he came actually to the biggest theater there. There was like a big show, and he put on he had 3,000 people show up in an indoor theater in Wilkes-Barre, PA, which is not that big a city. And he advocated a 70 to 80% carbohydrate diet, less than 10% fat. If anybody's ever tried that, it's pretty difficult, and 20% protein. And this was hailed as the new normal. It didn't quite work out all that way. Earlier, there had been the Mediterranean diet was actually written about in the New England Journal of Medicine in the 1960s. And that's pretty much a balanced 40% carbohydrate, 40% fat, 20% protein. It's pretty close to the paleo diet. It's almost the same. And the zone diet was another, just a little bit of slight alteration. The keto diet, ketogenic diet, is a high fat diet with about 20% protein and just about 5% or 10% carbohydrates. And Robert Atkins was a physician in New York City. He had written the Atkins diet in 1972. He was actually subpoenaed in front of Congress to explain himself. And he was determined, it was decreed that his methods were, medical suicide, quote unquote. He made a resurgence again in the late 90s after, it became pretty clear, what happened with the low fat diets. So what do we do with this? So we're going to measure. We like to do some measurements. So we look at blood sugars, of course, and we look at blood sugars 3 different ways. So we look at it, I liken it to the Christmas Carol. We're going to look at blood sugars of the past, present, and future, like we're going to look at the Christmas of past, present, and future. So the past is actually going to come next, but the fasting blood sugar, we consider that the present. Now, when I was an intern way back in the dark ages, at Metropolitan Hospital in Philadelphia, which is actually now a condominium. It's not even a hospital anymore, but the patients would come in if they were diabetic. As long as their blood sugar was under 200, that was considered acceptable, a fasting blood sugar. It then was kind of standardized at 125, and now it's at 65 to 99, and that's considered normal. We look for optimal. Those ranges are just way too wide. And this paper down here was written in 2008 by Nicholas and friends, and he looked at normal plasma blood sugars, and they followed these patients for 15 years. And what they found is that patients that had fasting blood sugars of greater than 84, for every point over 84, they had a 6% increased incidence of diabetes. So a patient who has a blood sugar of 94, fasting blood sugar, they have a 60%, so 10 points over 84 times 60% increased incidence of diabetes within 5 to 10 years. That was the time frame that they looked at. So I do this with every patient all the time, and it's, I tell them, it's normal, it's just not optimal, and that's kind of what we want to look at. Hemoglobin A1C, that's pretty standard, a blood sugar over 3 months, and it's a percentage of the hemoglobin that's glycosylated with glucose in the bloodstream. Less than 5.7% is considered normal. 5.7 to 6.4 is pre-diabetes, and greater than 6.5 is diabetes. There's lots of false positives and negatives, but this is a pretty standard test, and I'm sure everybody on here who deals with patients, knows all about it. We also look at insulins. We do fasting insulin. Normal is 2.6 to 25 almost. Our goal is really less than 5. We want the patients to use as little insulin as possible, and we can calculate an insulin resistance. And we follow this along. So fasting blood sugar times fasting insulin, you're going to divide it by 405. That'll give us the proper units. We want it to be less than 1.9. And we're going to follow this along. So you're going to find a patient that has a fasting blood sugar of 90 and a fasting insulin of 15 is going to have a high insulin resistance. And again, this is another clue that even though they're normal, they're not quite optimal. And one of our goals is to sort of head off as long as we can any of these long-term obligations. We also look at homocysteine. Homocysteine is a form of looking at some nutritional markers. It's also a marker for artery damage, particularly coronary artery damage, also carotid artery damage, heart attacks, and strokes. Our normal is less than 11. Our optimal or our goal is less than 10. Our remedies are methylated B vitamins. Vitamin D, we can do a whole seminar just on that. It's necessary for calcium and absorption, bone strength, the immune system, the heart, the brain. Anybody that dealt with the COVID patients over the last 3 years knows that the higher the vitamin D levels, the less severe the symptoms were. Normal in most labs is 30 to 110. Optimal is 50 to 80. We do a whole laboratory thing. I'm not going to go into where we got that, but if you're interested, let me know, and I'll give you the calculations. This is a micronutrient test. There's lots of companies that have it. This is a serum test, and they'll measure deficient, sort of borderline, and adequate nutrients. There's 32 specific nutrients in this test. These are vitamins from A to K, the antioxidants, neurotransmitters, and also give you a balance score. There's an organic what is it called? OAT, organic acid test. That's what it is. There's another one. It's a little bit more sophisticated. It takes a little bit more time to interpret. These are some of the quick start things that we use to get the patients going on their journey. Body Sight has has at least one program for each of these, and you can just type in elimination diet or autoimmune protocol. Protein sparing modified fast and intermittent fasting are pretty much the same thing. And then we're going to talk about some of our game changers. I'm just going to mention inflammation briefly. Again, having been raised in a previous medical paradigm, the concept of chronic inflammation is a little bit beyond me. So I lived for 30 years in Wilkes-Barre, Pennsylvania, coal country. This was a town about 60, 70 miles southwest of it. And basically what you're seeing here is that due to a series of political mishaps, the town was set on fire underground. It was an underground fire that it was set on fire in 1962. It's still burning. And this is what you see. You'll see smoke coming out of the ground. And actually, by 2002, the town was condemned. Here's a picture of the town in 1962. This was Main Street, and this is a Main Street in 2002. And you can see it's completely wiped out. And so this is kind of an analogy. This underground mine fire is supposed to keep burning until, those of you that are Star Trek fans will know that Captain Kirk was born in 2250, and it's estimated that that's when this fire will burn itself out. It's called Centralia, Pennsylvania. There's even that's burning even as we speak. If you're at all interested in it, it's kind of an interesting history. So what are we going to do to look for inflammation? So we like C-reactive protein. There is SED rate, but I think this one's a little bit more sensitive. 0 to 3 is normal. Our goal is less than 1. It looks at inflammation primarily in the cardiovascular system. It gives us a good handle on chronic diseases. Now, if somebody has a cough, a cold, an infection, these numbers are going to be quite high. I had a patient come in with an ulcerative colitis, and it was 71. But that's not really what we're looking for. We're looking for subtle changes. So a patient who started out, say 6 months ago, and he was 0.8, and today he's at 1.4. They're both considered normal. Your lab studies will not flag it. And that's a concern to us. These are not specific. These are telling you something's going on to go look for it. Our remedies actually for this, though, when they're high, when they're over 1.0, we'll look at omega-3 fatty acids and turmeric, anti-inflammatory substances. And you know, omega-3 fatty acids are good as an anti-inflammatory and antiplatelet. It supports mental health. It has some antidepressant properties and some cardiovascular health. Turmeric or curcumin is a good as a liver detox. Make sure you use it with black pepper or bioprene, it's called, to help it be absorbed. LPPLA is a marker for vascular inflammation. For it's a predictor of coronary artery events. It has to do with plaque vulnerability. The next one, MPO, myeloperoxidase, has to do with plaque rupture. So a high LPPLA and a normal MPO says, you know, that's warning Will Robinson. High MPO, which is going to be the next one, tells us that you know, we have a more serious issue. Niacin, omega-3 fatty acids, statins, and fibrates are our goal. Here are the normal lab values up here. MPO, as I mentioned before, this oxidizes LDL, bad cholesterol. This high numbers here indicate plaque rupture, and this is a more serious issue. POM is pomegranate seeds, believe it or not, curcumin, aged garlic, and quercetin. This is our hierarchy then for the road to inflammation. A high carbohydrate diet leads to increased insulin and a chronic inflammatory response. We get these cytokines, the inflammatory proteins become elevated. We start losing glutathione and our ability to handle the inflammatory compounds. We get fat accumulation, skeletal muscle inflammation, and it's the road to chronic diseases. The labs we just mentioned: C-reactive protein, LPPLA, and MPO. Chronic inflammation leads to weight gain. You knew I'd get around to it eventually, Katrina. So chronic inflammation leads to a decrease to T4 to T3, which leads to a state of thyroid resistance. Thyroid holds in weight. Thyroid is your gas pedal. It tells your body how fast to go. It affects every cell of the body. Low thyroid function leads to weight gain. It increases insulin resistance. It increases leptin levels. It increases appetite, and it increases the inflammatory cytokines. There's inflammatory proteins, interleukins 1, 6, and TNF alpha. It also can lead to lower testosterone levels, which can increase in aromatase, leading to high estrogen levels. High estrogen levels lead to fat, particularly in the belly. Hormones need to be balanced, and we do this, with every patient. That's kind of our specialty. I'm not going to go through this because this is a whole different story, but what I've given you here is basically just a hormone summary with the properties, what to look for each hormone, the functions and deficiencies here. So again, that's a whole nother course. And I actually have I'll put in a shameless plug. I actually have a CME accredited video course on hormone optimization from the beginning. So that's our shameless plug. Here is our evaluation. Serum, you can do saliva and urine. A lot of my colleagues will only do saliva and urine. The state of Nevada doesn't like that, so they sort of force us to do serum. So I got quite comfortable with it. But if we're stuck with anything, we'll certainly do the saliva or the urine test. And pretty much everything that we talked about here. And so let's get to it, the interventions. So I'm going to just briefly mention some of the older things that we used. Phentermine, topiramate, buprone, naltrexone, which the trade name is Contrave, HCG, which we can't really get anymore. We can only get it in the commercial product. We did use that quite a lot, paired with a 500 to 800 calorie diet, and I know Body Sight still has your program for that on there. Naltrexone, let's low dose naltrexone actually, and we sometimes do implants on that, and then we'll talk about our incretins. Down at the bottom here, these are some of the add-on things that we'll use to increase metabolism, burn fat, and a couple of other things, especially if the patients can't tolerate the incretins. We like tesofensin and MOTS-c, which is a peptide. And I'm going to talk about this combination here. This is really hot off the press, and we're starting to use this now for our maintenance program. I'll give you the reference on that. This just came out in April of 2023 with using this combination of metformin 500 milligrams once a day, and it's Mirbertic is the trade name. They used 100 milligrams, and they found over 6 months about a 17% weight loss just using a paleo diet and this combination. So we're starting to use this as our maintenance program. We'll talk about Mirbertic. There is an issue with it that's a little bit vexing. So just real quickly, phentermine basically is speed. It's an adrenergic reuptake inhibitor. It stimulates the nervous system. Anybody who's taken it, especially if you're sensitive to it, have high blood pressure, you'll start shaking like a leaf. It increases energy. It's an amphetamine-like medication, 37.5 milligrams scored tablet. You can break it in half. It can be made as low as 15 milligrams. You take it an hour before breakfast. And side effects, there's a lot of them, tachycardia, elevated blood pressure, dry mouth. There's a lot of drug interactions here. You need to be a little bit careful with it, but we have used it fairly extensively. A lot of patients do, especially the younger patients, do quite well with this. And they'll lose 5 to 10% of their body weight over about a 6-month period on here. If they stick to an exercise program and a reasonable diet. Topiramate, Topamax, was always paired with it. We used to use phentermine in the morning and topamate at night. It's an anti-seizure medicine. This is an off-label use. Well, actually, it's not off-label now because there's actually a combination that's called, I can use trade names, right? Is that okay? Trade names are okay? Okay, yep. So this combination down here is called Qsyma, Qsyma, I think it is. And it's topiramate and phentermine in one pill. It's a lot more expensive than if you just take them separately. Off-label use for topiramate is migraine headaches, prevention of bipolar disorder, seizures, and it actually acts on the frontal cortex to reduce appetite. The doses that I've seen are anywhere from 25 to 800 milligrams. Usually 50 to 100 milligrams is adequate as an adjunct to the phentermine. You use this one at bedtime. And some side effects are memory loss, dizziness, fatigue, brain fog. Quite frankly, again, I don't use this much anymore because of all the new things, but when we did use this, it was pretty benign. We rarely had any side effects from this at all. The phentermine, we did have some problems with increased heart rate. So naltrexone, bupropion is so low dose naltrexone is a potent anti-inflammatory, and it increases endorphins. In anything less than 4.5 milligrams, that's in the separately, that has to be compounded. This is a combination. This is an FDA approved drug. It's called Contrave. Quite frankly, I've never really had a lot of success with it. Theoretically, it should help. It targets the CNS pathways influencing food intake. Naltrexone suppresses neuron inhibition in the hypothalamus. It should increase energy and decrease appetite. You have to use a lot of pills. Like I said, it's FDA approved. In my experience, it's not. We've not had a lot of success with it. Low dose naltrexone is a compounded, watered down version of naltrexone, and again, this is a whole nother topic that we can spend time on. But in the realm of weight control, it reduces insulin resistance. It increases growth hormone, which will increase metabolism. It burns fat. It reduces lean body weight. It decreases cravings. It modulates the opioid pleasure receptors. It acts as an anti-inflammatory, and it improves sleep, and it increases that conversion of T4 to T3. Remember, the inflammation slows that down. Very few side effects. I found in the literature, it says nausea 32%. In our experience, we use this a lot for a lot of things. We use this for all sorts of autoimmune issues. We rarely have anybody have to stop it because of nausea. We do like to dose it at bedtime. It works by blocking the opioid receptors for 6 hours. Then it wears off. In the 6 hours that it's working, it creates endorphins, and it stimulates anti-inflammatory cytokines. When the medication wears off, the opioid receptors are then flooded with the anti-inflammatory cytokines and the opioid receptors. About 10%. So we like to dose it at bedtime so that your patients are ready to go in the morning. But about 10% of the patients experience an insomnia. It'll happen the first night or two. That will happen, and you'll know right away. There's a whole schedule of lowering. Taking it 2 hours earlier until the insomnia goes away. It got to be a little bit too much for me. So if the patients have insomnia, I just tell them to take it during the daytime. We've not had anybody have to stop it because of that. The other thing that's there, the books call it vivid dreams, which are nightmares, and there's actually 20% of the patients will report that, and they'll tell us some kind of wild stories. Again, a lot of them like it, and we don't really have anybody have to stop it because of that. Naltrexone can come as an implant too, like a pellet. The pellets are 1.1 to 2.2 grams. You can use them. They're good for about 4 months. And again, they'll eliminate not all cravings, but they'll lower cravings. You still have to do your lifestyle changes. And that took us. Now we're up to it now. So I'm going to call them the incretin hormones. I'm going to change it from semaglutide because there are 2 of them that are FDA approved, and there's a third one that just 2 weeks ago on May 30th was started their phase 3 studies, and a big study came out just on Monday, and I have it here. So incretin hormones are gut peptides that are secreted after nutrient intake. They stimulate the increase in insulin secretion by 2 to 3-fold. There are 2 types: glucagon like peptide 1 and glucose-dependent insulinotropic polypeptide. So there's 2 different types. They work a little bit differently. The first incretin came out in 2005. It was called Byetta. It was a daily injection. A newer version came out a couple of years later called Bydura, which became a weekly injection. So the glucagon-like peptide 1 stimulates insulin secretion, and it inhibits glucagon. It controls appetite and cravings. It slows emptying time from the stomach. It increases resting energy expenditure, and it improves sleep. And this is your GLP-1. This is your semaglutide. I've also heard it pronounced semaglutide in some places too. So I'm going to use semaglutide because I'm from the East Coast. So glucose independent insulotropic polypeptide is the second of the incretins. This one activates glucagon receptors. It induces insulin secretion. It prevents apoptosis, which means death of pancreas cells. This is where insulin is secreted from, generated. It stimulates glucagon secretion and fat accumulation. It influences hippocampal regulated memory and appetite and satiety. And it actually works somewhat in bone remodeling, and has been used as an adjunct for osteoporosis and fractures. So, the GLP-1, that's your semaglutide. The GIP, it's GLP-1 GIP, that's your tipirazide. I think I can never pronounce it right. Manjaro, something like that. So those are your two incretins. These are all the incretins. So these are the early ones. And you see here, Januvia, which is an oral agent, is actually considered an incretin also. So the first one came out in 2005. Biduron, which became the weekly one, was 2012. Victoza in 2010. Trulicity, this one here I've not really heard much about. Trulicity has been out since 2014, and we used to get calls for this for weight loss also, but it was kind of cost prohibitive. So in 2017, Novo Nordisk came out with semaglutide, a once-a-week injectable with improved glycemic control, and this was a big jump. This was really one of the first, the better, this wide side. The weight loss is a side effect, basically. It tells your brain that you're not hungry, and it was three times there was threefold increase in weight loss with semaglutide Ozempic than with all of the other incretins, and even our other interventions. Rybelsus is the oral form. I don't have a whole lot of experience with that. Maybe somebody does here. And then in 2021, Novo Nordisk took semaglutide, reformulated it a little bit, changed the doses, and it got an FDA approval for weight control. In 2022, tirzepatide came out, Mounjaro, which is your GLP-1 and GIP agonists. And I have a hard time pronouncing this one. This is brand new. This information came out, and I'll show it to you a little bit later, June 26, 2023. Today is June 28, 2023. But this has been studied for a little while, and this is called retatrutide. It's not FDA approved yet. They just finished phase 2 studies. They started phase 3. And this is a GLP-1, GIP, and glucagon agonist. And according to the gurus in this field, this is supposed to be the holy grail of the weight loss incretins. And what you're going to find is that the weight loss is much better here, with much less side effects than with even semaglutide and their tipirazide. So we'll talk about semaglutide first, because this became our first game changer. This was a study done in came out in 2021. It was a 68-week study. Patients had 14.9, almost 15% average weight loss. A third of the patients lost 20% of their weight, and 70% of them lost at least 10% of their weight. And that's pretty much been our experience. That holds pretty well. Unfortunately, men lose weight more easily than women. But even we've had women lose up to 30 pounds in a month, with an average weight loss of about a half a pound a day for women and about a pound a day for men, if they follow a diet. It controls appetite and cravings. It slows stomach emptying time. It stimulates insulin secretion. This one inhibits glucagon. It improves sleep and increases resting energy expenditure. That's how it works. It's 89% bioavailable. It peaks in 1 to 3 days. You get steady states over a week, and you get in a week it'll sort of stabilize, and you'll get a steady state in over 4 to 5 weeks. The half-life is about 7 days, so it's a long-acting medication. This was a 40-week study done in 2021 with Wegovy, which was the 2.4 milligram per week. And the highest dose here in this 40-week study was 16.2% weight loss. This is placebo here. This red one here, this is Trulicity. This was one of the older ones. And these are other doses of the semaglutide. The higher the dose, the more the weight loss. This shows, again, this was that 68 weeks. This was a placebo, and this is the 16% weight loss, average weight loss with semaglutide. But there's danger, Will Robinson. Again, those of you of a certain age will remember Lost in Space and the robot here. There's a high incidence of side effects. This is the official rate. Nausea, 44%. Nausea to the point where the patients can't take the medication. And there's a high incidence of discontinuation of the medication because of this. Diarrhea, vomiting, constipation, abdominal pain, headaches, and fatigue. Now, there's some ways around it. The most important thing you need to emphasize for the patients, if they're going to just continue their eating ways, they're going to get sick. If they're going to eat junk, if they're going to McDonald's 3 times a week, if they're eating, if they're not eating whole foods, plant-based foods, if they're just eating, if they're just, going, their high carbohydrate diet, they're going to get sick. The patients who don't get sick are the ones who change their eating habits, and they do much better. And almost to the point where we have less than 4% discontinuation rate when we follow that plan. So this is what we do. So again, most important, no junk food. You also have to limit the size of your portions. Also, 500 calories in a meal, is probably probably the max that you want to do. We don't really have people count calories, but you can't go to the buffet at the casino and just load up on it. I mean, you're going to get sick. The Body Sight program is really great. And it saves us a lot of time and effort. We just put the patient's names in there. We send it off. We check in with them, make sure they're doing it. They'll check in with us also. We always have our patients get some fresh ginger. Ginger seems to really calm the nausea from the semaglutide. And so we tell our patients to always have some fresh ginger around. As far as interventions, prescriptions, promethazine, Zofran, Pepto-Bismol, those of us in the sort of alternative world, zinc carnosine is a good choice. L-glutamine is another good choice. Again, I'm allowed to use the brand names. So we like Orthomolecular makes a powder called GlutaShield, and it has the zinc carnosine in it. It has deglycerinated licorice, which we use for gastroesophageal reflux disease. It also has L-glutamine in it and has some digestive enzymes. We really like that one. It's not expensive, and it actually tastes good also. So vitamin B6, we'll talk about that, and BPC 157. If you're not familiar with that, it's a peptide. It's a kind of a growth hormone derivative. It comes from gastric juices, and they're potent anti-nausea agents. And we've used these very successfully to decrease our nausea and actually diarrhea incidence, discontinuation rate. Our discontinuation rate is less than 4%. And the official from the company is 44%. So I think we're doing a fair job. And these are the 2 main agents we'll use. I'll talk about them in a minute. Diarrhea, you want to increase fiber. You want to make sure they're hydrated, and allopurinol, Imodium, if they need that. Vomiting, again, the same as nausea. the promethazine, Zofran. You want to avoid really high fat diet foods, especially right around or the day or two after the injection. And again, there's their L-glutamine, deglycerated licorice, zinc carnosine, and aloe vera, and our B6 and BPC 157. Constipation, this is fairly common because you're going to decrease gastric emptying. That's what the drug does. You're going to use some high fiber foods, figs, dates, green leafy vegetables, Miralax, Metamucil, the old standards. Cod liver oil has a lot of good uses and effects. Magnesium, particularly magnesium citrate, aloe, pectin. These are all sort of remedies. Abdominal pain. So one of the sort of be on the lookout for is pancreatitis. I've not seen it. We've been using this drug for well over 2 years in this form now, and we've not seen it. But it's always in the back of our mind. So you always need to make sure somebody who starts calling about abdominal pain, we have to make sure that they're not suffering from a pancreatitis. We use castor oil packs, Epsom salt baths. Again, licorice root, black cumin is a good choice. And again, ginger and mastic gum. And usually these comes in combinations. That GlutaShield works nicely. There's Apex Energetics makes one called Glucoflam, Glucoplan, I think, Glucoflam. Headaches, 14%. Make sure you check their blood sugars. One of the nice things about the semaglutide and all the incretins that we use is that if the patient's blood sugars are normal, we rarely, if ever, see an episode of hypoglycemia. I think I have some statistics coming up and you'll see it's almost non-existent. That was one of the things we worried about. Gluten-free diet. I'm firmly convinced that everybody should be on a gluten-free diet. Regardless of your status. Gluten is just not good for anybody. Increased fluids, magnesium. If you like essential oils, peppermint oil, lavender oil, arnica, rub the oils on the back of your neck or your temples. Arnica, feverfew, butterbur. Vitamins B1 and B6. If it seems to be related to menstrual cycle, we use some progesterone cream on the temples. You can get a 2% or a 5% over the counter. You don't need a prescription for it. And one of my other hats, as you can tell, I get bored easily, so I go and learn lots of stuff. So I'm actually an acupuncturist also. So Battlefield Acupuncture is taking little tiny gold needles and putting them in these spots in the ear, and usually within 10 minutes, the headaches are gone. I mean, it's pretty dramatic. Fatigue. We want to watch out for food sensitivities, the leaky gut syndrome. Again, B1, B6 replacement. D-ribose is a B-type vitamin, which is good for energy. Check their magnesium, check their potassium, and of course, stress reduction techniques. Some other tips for success. The weekly dose. I have it here on Friday. You want to make sure, especially early on, that they're free the next day or two. You don't want them to have a big presentation on Thursday and have them use their shot on Wednesday, especially right at the beginning, and have them become ill. So you want to have. So we usually encourage them Thursday or Friday, especially if they're off on the weekends, to have light meals for the next 2 days, and to test things out. And again, no junk food. We have ginger on hand for them. We tell them to have a little Pepto-Bismol on hand, and a little bit of it seems a paradox, but a little bit of a fat snack. So some coconut oil or some avocados usually will help ease the nausea also. Make sure they drink a lot of water, 6 to 8 ounces a day. Remember, what the drug does is it decreases their appetite. And we have seen on occasion, rarely, but on occasion, someone not drink enough and they end up with a bit of dehydration. We usually have them put a half a teaspoon of sea salt or pink Himalayan salt in one of the glasses of water. They need to do some physical activity. Do what you like to do. move throughout the day. You know, some of us sit in front of a computer and flap our jowls all day like I'm doing, and I don't know if that's what Katrina does too. So you need to move around a little bit. Try some new recipes. You know, the Body Site's great for that. They have all sorts of recipes in there, and there's all sorts of diet plans. Before the semaglutide diet plan, we would pick out one for the patient, or we'd offer it to them. And our most favorite were either the paleo or the keto, or the Mediterranean gluten-free. That one seems to be pretty popular too. Some warnings. Family history of medullary thyroid cancer is considered a contraindication. So if you ever see how some of these studies are done, they feed rats 400 times or 500 times what a dose would be for their body weight. And then the rats ended up with medullary thyroid cancer. So anybody with a history of it, that's considered a no-no. Routine monitoring of calcitonin or using thyroid ultrasound is kind of uncertain. And so just be aware of this. Again, I've not seen it at all. I haven't seen anybody have a thyroid issue with the semaglutide or a tipirazide. Weight loss in general, we've seen this over the years. Hypoglycemia, again, this is a hypoglycemia drug, although we've not seen this. Cholelithiasis with rapid weight loss is an entity. So be aware of that. You can get a little bit of an increased heart rate, and patients that were previously depressed get a little bit less depressed, and it's been documented as suicidal behavior and ideation. Again, I've not seen any of this. I mean, most of our patients are over the moon. This is probably one of the best things we've done in 40 years. Food choices, and I told Katrina I stole this right out of the Body Site program. So the A foods are your fruits, non-starchy vegetables, whole grains. I put in with caution. Grains are gluten's not so terrific for anybody. Nuts and legumes, high protein foods, and your good fats, coconuts and avocados, and stay away from the junk. Fried food, white flour, white sugar. Dairy is actually, if you're sensitive, you can get an allergy-like syndrome. Refined grains, sugary drinks. Alcohol's not so good for you either. So right now, our main recommendation is the Body Site plan plus the gluten-free diet. Here's a dosing schedule. For the semaglutide, we're going to start at 0.25 milligrams once a week. For a month, for every 4 weeks. Every 4 weeks, we increase the dose, and you can go up to 2.4 milligrams. That's Wegovy. If you're using Ozempic, it only goes up to 1 milligram. Quite frankly, we see pretty good results with up to 1 milligram, and we rarely go any higher. I just don't really seem to need it. Somebody else has a different experience, can let us know. But the lower doses, as long as you moderate what you're eating and get some exercise, seem to do quite well. So one of the problems is cost. So at the moment, there are some off-label ways to get around that, but I think it's going away, and I don't even want to get into it anymore. At this point, the drug companies and FDA seem to be cracking down on the compounding pharmacists that have been making it. So for right now, what we're doing is we're going to be doing the once-a-week shot as prescribed, and we're going to add in our little extras here. So this little chart here is kind of a summary for semaglutide. It'll tell you what it does and what it is. Glucagon-like peptide 1 analog, approved for FDA for diabetes, and the higher dose Wegovy's approved for weight loss. And what it does: controls appetite, craving, slows emptying time, increases resting energy expenditure. BPC 157, like I said, is an anti-inflammatory agent. It actually comes from gastric juices. It was actually identified in 1904 by Pavlov of Pavlovian dog fame. He didn't really know what he had, but they were using it in Tsarist Russia for upper GI issues. And it was identified fully in 1993. It is an anti-inflammatory agent. It promotes vascular formation. It comes as an injectable. It comes as in an oral form. In an injectable form, it's extremely effective for joint disruptions, joint pain, arthritis. those kinds of things. Any type of GI issue, leaky gut, irritable bowel syndrome, ulcers, ulcerative colitis, it has a good effect on. It is a potent anti-inflammatory agent, and vitamin B6 is used 25 milligrams up to 3 times a day. It's used in OB now for morning sickness. And so we put it all together. We got our weekly semaglutide shot, the BPC 157 B6. We'll use that as our anti-nausea agent. We do 10 weeks on, 2 to 4 weeks off. The literature tells us that to use it continuously. It's been our experience that if the patients don't take a break, they get accommodated to it and it stops working, especially for weight loss. We added in another, so berberine is considered the herbal semaglutide, and we added in, we added this brand in, which is, again, I can talk about brands, it's from Numedica. So it's berberine Vaso QX 3 times a day. It improves energy demand. It's a central regulator of energy homeostasis, and it contains gynostemma, which is an AMPK or energy regulator. Basically, it's a fat burner. So a lot of us have used berberine. You said we didn't really lose weight, but you have to use it in a fairly high dose. You need 1,500 milligrams a day. So the diet, so we recommend is Body Sight. The Body Sight program will sometimes do Mediterranean, keto, paleo, or the autoimmune diet. If you have a sweet tooth, 2 tablespoons of apple cider vinegar and 6 ounces of water, and you can do that 2 or 3 times a day. Usually kills the sweet tooth. That works quite well. For exercise, high interval intermittent training, that HIIT, I'm not saying it right. And then we decided to have a little bit of fun. So we went back into the archives. YouTube is great for this now. Those of us of a certain age probably spent $100 for a tape for 8-minute abs, 8-minute legs, sweating to the oldies, buns of steel. You can do all of these exercises in 8 minutes. There's no equipment. You don't need a gym. You don't need, a pair of, you need a pair of shorts and a t-shirt. You don't have to go anywhere. It doesn't cost anything. And the exercises are perfectly fine. They're wearing, everything looks campy. They got the 1980s hairstyle and the spandex and whatnot. Those are kind of fun. There's a lot of them. And that's kind of what we recommend. And it works out quite well. I've been doing 8-minute abs now for myself for more than 2 years. For maintenance, we talked a little bit about the metformin and Myburdic. The problem with Myburdic is that it's at the moment trade name only, and it's quite expensive. So we can, for metformin, if you don't want to use medications, we can use the berberine. You need 1,500 milligrams a day. Chromium picolinate, about 1,200 milligrams a day. For the Myburdic, we use resveratrol, 1,500 milligrams a day, and curcumin. And you can use either one of these. You don't need both. These are a couple of other things that we can add in. So now let's talk about tirpirazide. How am I doing on time here? We okay? Okay, so tirpirazide, this is Morgiano, right? Did I say it right? Morgiano. So this is from Lilly, and this is the GLP-1 agonist and GIP. So this is semaglutide with the other incretin hormone. You get an increased satiety, increased weight loss, decreased appetite. The dosing numbers are different. Basically, we see a better weight loss with less side effects with tirpirazide than semaglutide. This actually is, here's your weight. This is the weight difference from tirpirazide to semaglutide. We get the lowest, this is the lowest doses of each. You get about a 1.9, this is the difference in weight loss, 1.9 kilograms better with the tirpirazide. The highest dose, 5.5 kilograms, which is about 12 pounds for the tirpirazide versus the semaglutide. The side effect profile, as you can see here, is almost the same, but a little bit better for tirpirazide than semaglutide. And hemoglobin A1C blood sugar response is much better with tirpirazide versus the semaglutide. I mean, it's not bad for semaglutide, but it's a lot better for the tirpirazide. The weight loss here is much better with the terpirazide. Also, it's a little bit more expensive though. Hemoglobin A1C is better. Cholesterol difference is better also. This is the HDL. This is, this one you want to go up. Semaglutide is in gray. The different doses of the terpirazide are in the light, medium, and dark blue. Incidence of nausea is less with the terpirazide also. And the incidence of hypoglycemia here is really quite small. I mean, there was one patient in the 5 milligram and one patient in the 15 milligram category, and none in the semaglutide. So pretty much none. We've really not seen it either. Injection site reaction, we don't really see a whole lot of that either. These kind of side effects are really pretty minimal. So then now there's retatrutide. Again, I have a hard time pronouncing this. And retatrutide has 3 receptors. So it's your GLP-1, GIP, and it has glucagon in it, which further suppresses appetite and increases energy expenditure. This was just finished. This study was done in September of 2022. It was a phase 2 trial. There was a 24% weight loss in 40 weeks versus 20% for terpirazide. And this was published Monday, June 26th. So I want you to know that we're right on top of everything here. 24% weight loss at the highest dose within 48 weeks. These are the other doses for the retatrutide. I don't have a trade name for it yet. They just started May 30th with just starting the phase 3 trials. It's not supposed to end until September of 2025, but I have a feeling we're going to see this a lot sooner. The other bonus with this is you have relatively liver fat reduction of 86%. So this actually improves fatty infiltration of the liver, and 90% of them have resolution of their hepatic steatosis. So this is this is something new, it's pretty spectacular. So in this phase 2 trial, just as a summary, 48 weeks, 24% weight loss at the highest dose, an average of average absolute of 58 pounds. The weight loss thresholds for all doses was 100%. At 12 milligrams, nearly half of the patients lost more than 25%. A quarter lost more than 30%, and you had very good lipid profiles, hemoglobin A1Cs also. This is another one I can't pronounce. This is an oral agent of the same, it's also by Lilly. Retatrutide is also from Lilly. This will be an oral agent. This is also in phase 2 studies. And after 36 weeks, a little bit less weight reduction, but this is a pill. This is not a shot. So, and this one's fairly new also. So this is just a comparison head to head from the lowest dose to the highest dose. So some semaglutide, the lowest dose, they had an 8% weight loss versus the retatrutide at 16%, terpirazide. These are about the same. Highest doses, about the same weight loss, a big jump again in retatrutide. So when that one comes out, that'll be the game winner. What to do when the party's over? Again, we talked about metformin and mirabegron. I can't say these. Myberdic, which is approved for overactive bladder. And again, the issue with Myberdic is that there's no generic and it's really expensive. Myberdic, there was a 11% decrease in body weight over 40 weeks by itself. There was a 4% weight loss with metformin at 500 milligrams twice a day by itself. In the combination, there was a greater than expected 17% decrease in body weight. So, what we started to do, we use a lot of berberine. So we've been using berberine and resveratrol as a substitute. We have some studies on resveratrol that's fairly comparable to these medications. At a high dose, 1,500 milligrams a day. And we'll report back in 6 months or so and let you know how that goes for us. Okay. The problem with this one here, the Migbedaron, the Myberdic, this is with a good RX, $400 a month. So that's kind of not practical. I tried getting it wholesale and it was like $700 for 5 doses. So it's really too expensive. So what they do, both of those drugs, they convert white fat to brown fat. They increase thermogenesis, fat burning. The metformin doesn't work all that well alone. There was a 4% decrease in body weight, but when you add it in with the McBurderon, we end up with 1 + 1 equaling 4. The subjects also showed an improvement in glucose utilization. A couple of other things, and then we'll wrap it up. So AMPK is a energy pathway. There's lots of ways to address it, especially with when AMPK is deficient. This happens a lot, with aging. We get abdominal obesity, loss of insulin sensitivity, increased cellular stress, mitochondrial dysfunction, chronic inflammation. So when we stimulate this pathway, it increases fatty acid oxidation and ketosis. It inhibits cholesterol and triglycerides. It inhibits adipocyte lipolysis. So these are AMPK activators. Methylene blue, which is actually commercially as a dye. It does come in a food grade substance. It's used in autoimmune issues. So there's metformin. There's ginger. We talked about ginger. Butyrate is short chain fatty acids fermented in the liver. It decreases insulin. It reduces insulin resistance. And there's gynostemma, which is a Chinese herb. It transfers fats into the cells and it decreases fat storage and it improves insulin resistance by 35%. That berberine, VASOXX from Numedica, contains berberine and gynostemma. So that's one of the reasons we like that. This is some more information on gynostemma. Butyrate is short chain fatty acids. It helps with weight reduction. There's references for that. Oxytocin, the love hormone, has some weight loss component also. So here's again a summary. This is our semaglutide terperazide injection plan. We'll use semaglutide and terperazide interchangeably. Here's a couple of ridiculous things now. So we're hearing this nonsense. And some people are just never happy with anything. So if anybody's heard of Ozempic face. So, it's a big surprise that if you lose weight, you're going to lose some fat in your face. So this was, if you look up Ozempic face, I blocked out our eyes. This is actually a picture that I got off of the Ozempic face article. I think she looks pretty good. And then there's Ozempic finger. You may have heard of this one. So you're going to lose some fat in your finger, and the rings and bracelets are falling off. This is first world issues. So I came up with a couple of my own. Also Ozempic butt is another one. So here's my own Ozempic Calvins, because you're going to lose weight, or then you're going to have to go buy new jeans. Here's Ozempic dress or Ozempic Chicos, because you're going to have to go get some new dresses. We also have like I said, a mind body program. There was also, I skipped over, this was Ozempic hat and Ozempic foot. So these are more things that we can complain about. If you go on YouTube and put in some of these things, you'll find these people saying, "What are you doing this for?" You're going to end up with Ozempic foot or Ozempic face. So if you end up with Ozempic face and end up with increased wrinkles, we can fix that too. We do a lot of aesthetics here. I'm going to stop there. Any questions, comments, complaints?
Yeah, so we have a couple questions in the chat box. I'll go through those for you, and then you can speak to them. And anyone else, if you have any questions as we go through those, feel free to send them in the chat. So the first question that came in kind of earlier in your presentation was, is the HSCRP more specific for cardiac disease, and should that be used instead of a regular CRP?
Yeah, that's the one we use. So we use it so often that I forget that there's two of them. We do to use the HS one. Yes. Okay.
The next question is, do you use LPA and APOB as a screen for further CV inflammatory markers?
Yeah, the answer to that one is yes also.
Okay.
Easy. Okay.
Another question is, will you address the lean body mass loss using semaglutide and tirzepatide?
Again, adequate exercise, adequate, lifestyle changes. You're going to get a little bit of lean body mass loss, but on the whole, the patients, do quite well. And we're not really seeing a real issue with that. And again, I could be wrong. Somebody could be out, could have a different take on it. But our patients lose a substantial amount of weight. They feel better. And this has been a real game changer for us. We do use intermittent fasting as one of our plans. And Katrina has the Mind Body program, and she's more than welcome to send it to anybody who wants it. Okay.
This next question is about, your slide says tirzepatide is given IM. It is given SQ, correct?
Sub-Q, yeah. Did I put IM? That was a mistake. Yeah, sub-Q.
This question, did they just come out with a new oral version? I think that's in regards to this latest one, the R1, correct?
That one, the one that I showed you beginning with the O that I can't pronounce, that's not out yet. There's one called Rybelsus, which is actually semaglutide in a pill form. We've had 2 or 3 patients use it, and they do lose some weight with that. I don't think it's as good as the injectables. And quite frankly, I think using the injectable, there's a psychological component to it also. Taking a shot versus taking a pill. I think we've always done some injectables in one form or another. Sometimes we use peptides, and we always do better with the injectables than oral form in the interventions that we do.
Awesome. This next question, you can speak into it if you do this personally, and then I can speak into what syncs with Body Sight. Do you follow body composition, and is there a preferred device to measure that?
I don't, because I don't have the equipment. We have a scale that gives us body fat, but there are very sophisticated body composition machines. Most of our patients, they'll go to a gym, they'll go to a trainer, they'll have that. So personally, I don't. Would I like to do that? Yeah, but someday maybe when I have a couple extra dollars.
Yeah, I can speak into the devices that sync with Body Sight. So we have the Inotech home scale, which obviously is not as accurate as those that you can, hold with the hands, all 4 appendages. It's the Inotech scale, syncs directly with the app, so the data comes through automatically. And then we are also integrated with the InBody scale. So if you do have a brick and mortar where you have that in office, that syncs with the platform as well. A question that just came in, I'll just give my little tidbit is it better to use the Body Sight intermittent plan or the semaglutide plan? The semaglutide plan, that is breakfast, lunch, and dinner. The recipes are lower in fat with lean proteins, including plant-based protein that incorporate whole grains, fruits, and vegetables, whole grains with caution, of course. I don't know if there's a preference, Dr. Clearfield, I don't know if you want to talk into if intermittent fasting is better. Perhaps it's not what's best for everyone.
Right.
But
we do it individually. Your semaglutide plan is fairly new to us, so the jury's still out. But it's a paleo-like, and that's what we've recommended. And we ask the patients, what if they have a preference. If they don't, we usually do go with either a paleo, keto. And like I said, I like gluten-free for everybody. I don't think anybody should be eating gluten ever, whether you're on a diet or whether you have any kind of medical issues, or if you're just, it's 14 years old. It's just not good for anybody as far as I can tell. Patients just feel better when they're off of gluten. It's not easy to do. I mean, it's getting easier, but it's not an easy thing to do.
can you comment on compounded semaglutide?
Yeah, well, I just did. It seems to be becoming a problem. I guess it was too successful, and we can't have nice things. So it was a lot less expensive, and it was very successful. So of course, we have to put the kibosh to that. So what can I say? So like I said, I gave you the our version of the commercial product. So,
Mhm.
yeah. And again, the intermittent fasting is beneficial to everyone. And I agreed.
I do need to check, but I am actually pretty sure that, our semaglutide planet has whole grains, but I think that it actually might be fully gluten-free. I need to do a double check. So don't quote me on that, everyone here, but, I'll include that in the recording as well, once I get confirmation on that.
You're gonna fix that you're gonna fix that or put up another one, right?
Yeah, I'm pretty sure it is.
Yeah.
Yeah, don't hold me to
You
it, but I'm pretty
change the
sure.
name of it to semaglutide to pyrazide or Incretin, to include, the new ones and the ones coming down the road. So,
Yeah, since you brought that up, you guys can be the first ones to know that we will be launching a tirzepatide program, and then based on Dr. Clearfield's suggestion, we'll also be launching just a general Incretin weight loss plan, so it won't be specific to any one medication. As you've seen here, as early as 2 days ago, this new research is coming out about this one, so we want to make sure that we have some evergreen plans for you guys to use as the research develops and more Incretin medications come out. All right. Have you used a metabolic breathe machine?
no.
Okay.
So
Intermittent
anybody has
fasting.
information on it, let me know. And can I put in another shameless plug? Tuesday night, as you know, Katrina, because you've been on, we have an integrative medicine webinar every Tuesday night, 8 o'clock Eastern, 5 p.m. Pacific. We've been doing it for 2.5 years. And if you have any information on the what was it, metabolic something breathing machine, we'd be happy to hear about it. So can I put my email address in the chat? Can anybody wants to, is that okay?
Yeah, of course. And I'll keep going through these questions while you do that. Eileen, you asked, how does your intermittent fasting program look like? We have 3 intermittent fasting programs. One is the Clean 28 intermittent fasting, which Clean 28 eliminates sugars, gluten, dairy, alcohol. Then we have the gluten-free Mediterranean intermittent fasting plan, which Dr. Clearfield mentioned earlier is pretty popular in his practice, the gluten-free med, and then it's just an intermittent fasting version. And then we have the intermittent fasting paleo plan based on our paleo program, intermittent fasting. Another question, are pre-diabetics being covered by insurance companies for Ozempic and Mounjaro?
I have no idea. We gave up on dealing with insurance companies about 2 years ago and haven't looked back. So I really don't know. I guess some of them might cover it, some of them don't. We get every day we get pre-authorizations for this or that, and we gave up on that too. We give the patients a letter when they start with us saying we're not going to do it because it was taking hours. I mean, we had one person just doing pre-authorizations, and like it or not, we're running a business. I mean, I can't pay a person 40 hours a week, to generate nothing. So insurance companies can turn us down. Don't ask about testosterone replacement. It's another story. So the answer is I don't know.
And that's okay. Well, I think that's all of our questions that we have here today. We will be sending out the recording later this afternoon. We will also be including in that blog article that has the recording, the mind-body connection handout that Dr. Clearfield mentioned earlier in his presentation. If you have any questions, feel free to email Dr. Clearfield. His email is there in the chat. If you have any questions about BodySite or this new semaglutide plan that we launched, you can email me directly at Katrina with a K at bodysite.com. So thank you, everyone, and I hope you have a great rest of your Wednesday.
Thank you, Katrina, for inviting me.
Is there a link?
Of course. Thank you again. Someone's asking if there's a link to your Wednesday class.
I gave you my email address is right here. Okay.
Yeah, email him and then you'll get that over to them, I assume.
We'll get you going then. Okay.
All right. Thank you, everyone.
Okay.
Thank you, Dr. Clearfield, for being here with us.
Thank you.